for the evening, Dr. Alen Thomas. Dr. Alen Thomas, an MBBS graduate from CMC Vellore, furthered his education with a master's in general surgery at CMC Ludhiana, currently working at CMC Vellore as junior faculty. He initiated his career in the resource-limited regions of Uttarakhand and UP, showcasing a strong commitment to excellence. Driven by his dedication, he earned a PG diploma in family medicine from CMC Vellore. Specializing further, Dr. Alen Thomas completed a PG fellowship in vascular surgery, earning FMAS fellowship recognition from AMASI. As a proud member of ASI, AMASI, and CMAI, he is also recognized for his prowess as a presenter, having been awarded Best Speaker at CARES 2022 Ludhiana. Over to you, Dr. Alen.
Thank you, Shabnam. I hope my screen is visible.
Yes, Doctor.
Yes, participants can now see the screen. So great. And I'm audible also, I believe. I'm just waiting for a go-ahead from Vijay and you.
Yes, Doctor. You can.
Yes, Doctor, you can.
Thank you, Sain, and thank you, Dr. Lovepreet. Perfect, Jaswant. We'll start off. So without wasting any further time, let's proceed. So today's topic is mainly mastering abdominal pain. This is something, I have personally had a difficult time, understanding this topic clinically. You would read books and books, you would know what is tenderness, what is guarding, what is, all the different signs. But when it comes to patients, are you able to translate that whatever you have studied onto patients? So this topic of mastering abdominal pain, where clinical secrets that every physician should know, especially this topic is aimed at a lot of my friends and the doctors who are there in the periphery, in the mission hospitals, who are all alone by themselves, who are managing different hospitals single-handedly, working day in and day out. A big shout out to all of them. And yes, this is an upskilling course and an upskilling lecture. I hope you have a very good time understanding this topic, and definitely I look forward for a good feedback from your end, an honest feedback from your end, so that we can always improve upon ourselves. So yes, without wasting any further time, so this I would like to have it more as an interactive lecture. That's what my USPs of most of my lectures are. And I know because so many people have joined, let's do it in a way that you can put it in a chat box. I'll just activate my chat box so that I know, I can get your answers, right? Just a second. Yeah, I'll just put it somewhere in this corner of my screen. Perfect. So let's have an introduction on this topic. So abdominal pain is the most frequent among the most frequent complaints that an emergency unit will handle, accounting to about 5 to 10% of its presentations. This is not including trauma. This is just abdominal pain. So if you look at any abdominal symptom, something that really pushes the patient to the hospital is an abdominal pain, and it has no time, whether it's 2 a.m., whether it's 5 p.m., or even early morning 6 a.m. This patient will knock your doors if he has a severe abdominal pain. And you should never turn away from an abdominal pain. So accurate assessment is essential, of course, due to diagnostic difficulty, because we have multiple organs involved. And so this is the very essence of the lecture. Primary care physicians must prioritize life-threatening causes and initiate management early, so that you save lives. And if you require, you should know when to refer the patient. There's absolutely, I've told in my previous lectures also, especially when you're alone, there is absolutely no shame in referring a patient when you think it is beyond your control. It is better to do, you should not do any more harm, rather than, you should learn and understand the topic, do the best of your ability and proceed. So let's look at it's more of a clinical lecture, so very much less on theory. I'm sure you guys have learned a lot about theory, And this, I am taking vignettes from the theory part and pathophysiology and looking at more of the clinical aspects. So next 1 hour, I want your complete, honest concentration, and then I'm sure you'll be a good clinician at the end of it. So if you look at abdominal pain's pathophysiology, it may originate from different areas. Either it can be from the peritoneal cavity or behind the peritoneum, pelvis, abdominal wall, or extra-abdominal sources. So the wall, extra-abdominal sources, peritoneum, retroperitoneum, pelvis. So it's basically the entire abdomen. It can originate from anywhere. So what happens is whenever there is a mechanical stretch to these receptors, which are carrying your pain chemicals from the visceral and parietal receptors, that's when your pain triggers. Okay, so visceral pain is poorly localized and usually in the midline, and otherwise lateralized pain arises from structures like kidney, the ureter, or the ovary. Just a brief overview again. Acute conditions of the abdomen are produced by the routine thing that you write in the exam. Okay, inflammatory, obstructive, vascular, okay, etc. The multiple manifestations, of this abdominal pain. How does it do? The sudden onset abdominal pain. You may have GI disturbances like loose stools, constipation, and varying degrees of local and even systemic understanding. So if you look at inflammatory causes of acute abdominal, this is very, 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 very superficial. This is just to give a brief overview of the theory so that when you jump to clinical, everything falls into place. So if you have looked at the inflammatory causes, sometimes you would have eaten outside, okay, and you would have a bacterial food poisoning like that. So you may end up having GI disturbances. There can be translocation of bacteria within your gut itself. Otherwise, your appendix can get inflamed because of small fecolate that gets stuck. There, acute appendicitis, diverticulitis, and some cause of pelvic inflammatory diseases. Okay. If you look at chemical causes, sometimes what happens, the acid in your, there's overproduction of acid, recurrent hit of the acid on the stomach wall. And what happens is your protective mechanisms have failed. There is a perforation and the acid leaks out, and then you have an irritation of the peritoneum. The acid now hits the peritoneum, and you have these chemical causes. If you look at mechanical cause of an acute abdomen, you have obstructive condition like an incarcerated hernia. So what happens? The bowel goes in, or the omentum, the fat goes in through weakness in the wall of the abdomen, and then as long as it goes in and comes out, goes out, comes in, it's fine. But the moment the neck gets obstructed and it's not able to move, that's when you will have obstruction, and you have post-operative adhesions, intussusception, some malrotation of the gut with some volvulus, some congenital condition like congenital atresia or stenosis of the gut. However, if you look at the most common cause of large bowel mechanical obstruction, many at times it's carcinoma colon. So never, 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 a patient may come to you, say constipation for many, many years, or constipation, obstipation. Do not just give them at the spinal level. Do not just give them a syrup to wash out their bowel cleanser. So do not give them that, but rather evaluate. So if you look at so if you look at some vascular pathology, so as you know, all these organs are provided by some blood supply, artery or vein. If you look at the bowel, so sometimes there's a clot, or sometimes what happens, there's some obstruction to the blood supply to the gut, and that part necrosis. Same like a heart attack. What happens if the blood supply is cut off to the heart? You have something known as an ischemia, myocardial ischemia. So similarly, if you have some blood supply that is cut off because of a clot or any other pathology to the supply area of the bowel, that much area will, become ischemic and finally lead to necrosis. And anything that is dead or necrosed can have a perforation associated with it. Arterial thromboembolism. Sometimes the heart may have a clot, and when the heart is regularly pumping, the clot may just travel through the aorta into the mesenteric artery, and as you know, from the aorta, the vessels are becoming narrower and narrow with every as soon as it passes down. So like that, to an area where it cannot move forward, that forms a clot. So sometimes also you can understand there's congenital defects, and sometimes they cause an acute abdominal surgical emergency at time of birth, some atresia, omphalocele, diaphragmatic hernia, and chronic malrotation of the intestine. So this is just to understand if there is a process of, if you're suspecting inflammation, you have appendicitis, cholecystitis, diverticulitis. If you suspect perforation, what will perforate? Anything that is hollow can perforate. A solid organ not perforate. Let's get very simple to something that is fluid filled, air filled. If you puncture it, if any external source or internal pathology, what happens is you have a perforation, and then that is also biliary peritonitis. Then something known as obstruction. Just imagine, I want you all to imagine that you are in your kitchen and you've somehow washed some plates and you've put some food particles in the sink. So what happens is the water starts rising in the sink. Your outlet is, you have small bowel, large bowel obstruction. You can obstruct, in the biliary tree, or you can have a ureteric colic. Similarly, if you look at ectopic pregnancy, rupture leading to severe torrential hemorrhage and severe abdominal pain. So if a patient is suspected to be pregnant and she comes in the time to your casualty with hypotension, means low BP.
I'm so sorry,
Hypotension,
doctor.
severe
I'm so
abdominal
sorry,
pain,
doctor.
maybe.
Doctor?
All right, just a second.
Dr.
Sorry,
Alen,
give
your
me a
voice is
minute.
breaking. There is some network.
A second. Yeah, am I audible now?
Yes, you are audible.
Perfect. Sorry for the technical glitch. Just getting back. Is it better now?
Yes,
So very important in the slide is your hemorrhage part of it. Very important. A lady comes in, childbearing age, suspected pregnancy or early pregnancy, comes in with unrecordable BP, pale looking, severe abdominal pain, can be generalized, can be localized. Do not turn away this patient saying it is a gas or anything of that sort, because that is our common understanding. Any abdominal pain could be gas. All right. So avoid that. And, you should strictly look at management of ruptured ectopic pregnancy, giving fluids and managing hypotension. Aneurysm, ovarian cyst, or even spleen can have hemorrhage. Sometimes what happens is you can have torsion or ischemia, sigmoid volvulus, something the sigmoid will, rotate by along its long axis, or even testing in males, young males, adolescent males, you can, because the cord is hanging, what you can have torsion, or even ovaries in females can, undergo along its long axis, which will cut. What is the problem with torsion? The problem with torsion is the blood supply is also running along the cord or running along the, the ligaments touching the ovary. So when there is a torsion along the long axis, so what happens? The blood supply itself gets cut off. Okay, leading to again ischemia and other important things. So yeah, let's proceed. So just a quick thing, visceral, it can be mechanisms of abdominal pain. If you're suspecting visceral inflammation, could be, how could the pain present? It could be either colicky, dull, or burning kind of pain. What is the location? I'm going to explain this in detail. So I've just put it as a slide here, as a quick reference. Midline, somatic pain, or you can, the peritoneum is inflamed, sharp or aggravated by movement, localized. Referred pain, I'm going to explain each of these pain pathways. You can have dull pain. The problem is somewhere and you have the pain elsewhere. For example, your gallstone pain, you have the tip of the right shoulder, but tip of the shoulder. But what happens? Your pathology is in the anterior abdominal wall. anterior part of the front part of the abdomen. So that is kind of a referred pain. So what should I do when I'm stranded with a case of abdominal pain? This is the very question that every clinician needs to answer when he's gets in, and every abdominal pain, mind you, is different. So I have kind of tried to help you understand, because mostly these abdominal pains will land up in your casualty or in your emergency. You should understand that OPD also has abdominal pains, but they are those abdominal pains which have on and off, or they present to you saying, now I am better, I had an abdominal pain. So in the casualty, you don't have so much time to take a detailed history. So you just remember this mnemonic PQRST. Position, okay, what provoked the pain, was the quality of the pain, is it and region, severity, radiation referral, severity, and any temporal or other associated factors that it could have been the trigger for your abdominal pain. So PQRST. So basically it is P3QR3ST. 3 of P's, Q, R, 3, S, and T. So that's a mnemonic to remember for your pain assessment. Again, to continue, you have something known as a phrased approach. Again, phrased is just a word which has been, I've highlighted in the bold here. You understand the patient's problem, history, relevant medical history, any allergies, very important. Systemic review, any diabetes, hypertension, anything, to worry, thyroid, hypothyroid. Essential family or social history, and definitely has he consumed any drugs, or drugs as in it can be the substance abuse or the routine drugs he has taken, maybe empty stomach, or he's taken not as per the physician's protocol. Sorry. Proceeding. So what are these key history questions that you can ask in your one-liner questions, which will make you frame, get an understanding of abdominal pain? So either you can have pain is constant or intermittent. What's the severity scale? Is it really severe? Can you manage? Are you able to, for housewife, people who are not working at, going out and working, people are housewife. So one important history you can ask them to understand the severity. When you have abdominal pain, are you able to do or take care of the household, or do you catch the bed and you're lying down the whole day? Many Indian women try their best, even with abdominal, they have good tolerance. So even with abdominal pain, they will continue to be the people at home who will try to run the household. However, some of them is so severe, they will not be able to do anything and will be brought to the hospital. So that's a very important understanding of how severe is the pain and how fast you need to intervene. So any bowel or urinary symptoms. What are you looking at bowel? Whether you have loose motions, or you have difficulty in passing stools. Sometimes hard stools, not taken enough fiber, not taken water. You have dysuria, you have urinary pain. Any previous similar attacks, and then how were you treated? Was it medical management? Was it surgical management? Really, if you have those documentation, it helps understand the current pathology, because the previous pathology might be just carried over, or might be a complication of the current pathology might be a complication of your previous pathology. Any recent food intake, something that's different. Any allergies. Yeah, so menstrual or gynecological history, any recent travel or surgeries, family history of pain. Unlikely this, even though I've put it in the slide, but sometimes very, very rare scenarios are there where you can have, where patients say, okay, do you really, that mainly looks at the threshold of pain, sometimes some people are very, very pain sensitive. Some of them are very, very pain tolerant. Any substance use, medications, or alcohol. So going back, what is the origin of pain? Your three types of pain: visceral, parietal, and referred, which I put in the table. I'm just expanding those. So mainly the stretching of fibers innervating the walls of the hollow or the solid. So whenever they are distending or the fibers are getting stretched, These nerve endings are there. These receptors are there, and that will create a dull aching kind of. You can't localize it actually. It's a very dull aching. It can be due to early ischemia or even inflammation. Now, if you look at parietal pain, can be caused by irritation, parietal peritoneum fibers. Sometimes occurs late and better localized. Something that's in the peritoneum, you may be able to localize better, and the superficial localized to a dermatome, superficial to the site of the painful stimulus. Again, I will explain. So what about the referred pain is felt at a site away from the pathological organ. Again, so as I've highlighted, just for your understanding and exam purposes, parietal pain, dermatome superficial, referred pain based on developmental embryology. Now we look at pain location. Again, this is just a revision. So the organ, you have to see less severe pain, poorly localized parietal, again, easily localized, severe pain, it's quite sharp. That's your peritoneal related pain, and referred pain, again, localized, poorly localized. However, they share a common nerve pathway. Now, if you look at onset, you always ask, how did the pain start? Or what was the progression? Was it really going in, was it 100% in the beginning, then coming down, or was it started at 20%, then went up to 30, 40, 50, like that? Was it increased? So if you look at abrupt or excruciating pain, these are the examples: perforated ulcer, ruptured aneurysm, ureteric colic, stone pains that you have, biliary colic. But one thing I have put in here is an acute MI. Sometimes the patient will present with an upper abdominal pain. All right. So what happens in an upper abdominal pain is, if it's an elderly patient, he may or may not have an abdominal pathology, but his cardiac system might be failing, because of which he might be having he might be having a myocardial infarction, which is presenting as only as an upper abdominal pain, nothing else. So rule out, and if you don't treat the MI in time, you all are qualified. You will know that if you don't treat a myocardial infarction in time, the patient will die. So you don't localize your focus completely on the abdomen. You have to definitely look. If you have an upper abdominal pain, definitely look at, and and the age is also in that criteria, diabetes, has multiple comorbidity. Definitely rule out an underlying silent MI. Now, again, if you look at rapid onset, severe constant pain, acute appendicitis possibility, mesenteric thrombosis, sometimes when the blood supply is cut off, strangulated bowel, and you can have an ectopic pregnancy, which is probably ruptured. Then ectopic pregnancy may or may not have so much pain, but once it ruptured, then you can have severe abdominal pain. At the same time, hypotension, very, very important. My whole point is understanding many patients may not even reach the hospital, and it's a very sorry state of affairs. At the rural areas, clinics, when ectopic pregnancies happen, they may not be able to refer in time because they have not understood the pathology behind it. So you have to resuscitate. And at the end of my lecture, at least if someone picks up, an ectopic pregnancy well in time, the life of the patient can be saved. So again, this is a slide put on myocardial infarction, retrosternal pain. However, you can see where all the pain can radiate to. Again, the pain can individually radiate to even upper abdomen, because of the epigastric region, because of which you can have underlying MI is there, and then radiating to arm and all. So yeah, gradual steady pain. Okay, it's there. Sometimes it comes, sometimes it goes. That's a biliary colic. However, gradual steady pain, acute cholecystitis, it's just there. Okay, cholangitis, hepatitis, it's just there. Yeah. Intermittent colicky pain. Sometimes you can have early pancreatitis. Stone pancreatic, there may be a stone that is calculi that is moving. That can have an intermittent colicky pain. Am I audible?
You are, doctor. You are audible.
Okay. So obstruction, ureteric colic. Now, The other symptom that, a patient can end up to your casualty is vomiting. If you look at abdominal pain, may or may not be associated with vomiting, but if it is associated with vomiting, it speaks volumes. So it says whether it's a medical abdomen or a surgical abdomen. Mostly for a surgical abdomen, pain will be there before vomiting. Okay, because vomiting is first, usually proceeds before vomiting. So that's your surgical abdomen. If you know appendicitis, also they say, you have pain first and then you have vomiting. If you have vomiting first, unlikely or less chances that you may have appendicitis. It's not a absolute rule, but this is a clinical tip, or for understanding that, okay, pain in the surgical abdomen, for your antennas to be up, you need to know that pain usually precedes vomiting, right? And it can be reflex, irritating, non-specific vomiting, many conditions, and upper GI disease. If there's an obstruction and malignancy in the upper, so whatever the patient needs, he will immediately throw up. So when does he throw up? So if he has an upper GI, obstruction, something like a gastric outlet obstruction, so whatever he eats, immediately within less than half an hour to 1 hour, he will immediately vomit. So you know that the obstruction is very, very high up, and whatever he eats, he vomits. So upper GI obstruction is a possibility in that case. So what are the other symptoms? You can have acute gastroenterite, you can have diarrhea, in severe infectious conditions, you can even have dysentery. Dysentery, many here I want to, I've not put it in my slide. However, I want to bring across, when patients come to you, they will say, I have dysentery. There is a difference between diarrhea, and there's a difference between diarrhea and dysentery. Diarrhea is simple, one line understanding. Dysentery is with blood in stools. Diarrhea is without blood in stools. So if you have blood in stools, means it's a very, very strong infection. You can have Shigella, those kind of infection, giardiasis. So all that you need to treat, acutely and immediately. And food poisoning may be there, and you need to treat that, those kind of, admit the patient, hydrate. Constipation and obstipation. Constipation is a routine, OPD kind of a picture. When they say a patient come with, I say, I have constipation, I can't pass stools in the morning. But are you able to pass flatus? Flatus is gas, or in northern India, it's called wind. The common rural language, they call it as wind, hawa. So it is. Are you able to pass that? So if the clinical tip here, number 2, the clinical tip here is, if the patient is able to pass flatus, okay, or wind or hawa through this through his anal opening, what happens? What your understanding is that the patency from the mouth to the anus is present, at least partially. May not be complete, but at least partially. It is open. So do not try to feed that patient and make that partial obstruction into a complete obstruction. So the patient says, I am not passing flatus for last 2 days, I am not passing stools for last 2 days, then definitely there is something surgical underlying. If he's able to clearly say that he's not able to pass flatus, then definitely it is something surgical and should be referred to a surgeon. Or your understanding that if you have to refer this patient to a higher center, please proceed without any before the patient's condition worsens. Okay, jaundice, hematemesis, hematuria, of things. So past medical history, they may be under depression, and what happens is they may have these lot of antipsychotic medications. Many of its side effects is constipation. So you might be wondering, he may not have any pathology as such, X-ray is normal, ultrasound normal, everything, all the reports are normal, but these drugs are, as a side effect, the motility of the gut reduces. Thyroid disorder, if you are hypothyroid, not well controlled, that again causes constipation. So not all abdominal pain or abdominal symptoms are always surgical. So you should understand that, but when it is surgical, you need to pick up the surgical. So my professor used to say, a medical patient, if he comes to a surgical ward or gets admitted under surgery, he may survive. But however, if a surgical patient goes to a medical ward, gets admitted under medicine or medical ward, he is bound to die. Because until and unless surgical problems are corrected surgically or with a surgical acumen, you're definitely not going anywhere. All right. So yeah, these are multiple things. The anemia, drugs, herpes zoster, all these you need to ask as a history. Now, if you look at anatomical localization, okay, quickly look at anatomical localization. What is REQ, LEQ's right upper quadrant, left upper quadrant, light rower, left lower quadrant, epigastric, and suprapubic regions. So, I commonly ask this question to the medical students. How many quadrants are there in the abdomen? And how many regions are there in the abdomen? Can you quickly, put it in the chat box? How many quadrants and how many regions in the abdomen? I'm waiting. Yeah, see, as you can see in the chat box, every soul is confused. All right, sure, we'll come to that answer. So basically what you can do is, okay, I put up the slide on purpose because I wanted to ask this question. Simple. Quadrants, you can just divide them like your X and O kind of, or just divide them into two halves. All right. So you can have right upper, right lower, left lower. That's your quadrants. Regions are 9 regions, which I'm going to come across. All right. 9 regions are there. So just to understand the pathology, if you have a right upper quadrant, you have to think of the organ. So whatever the patient says, I have pain in the right upper. So all your mind should go in those organs in that particular region or quadrant. So if you know whatever organs are available, under that particular quadrant or region, you will be able to pick it up. So either it can be a subphrenic abscess, cholecystitis, renal colic, pneumonia. Left can be a splenic infarct, gastritis. Again, gastritis is more like a pathological diagnosis. I would like to say that acid peptic disease. If you look at right lower quadrant, you have appendicitis, cecal obstruction, nephrolithiasis, even tubercular, amoebiasis, all that in the right lower. Left lower can be diverticulitis, ulcerative colitis, nephrolithiasis, and epigastric. You can have multiple. You can have MI. You can have, now I have put it as early appendicitis here. So what happens is not epigastric exactly, but sometimes the patients say I have pain, the periumbilical region or just above the abdomen, it radiates down. After that, there's a shifting down. It shifts to the right lower quadrant after some time. So, and there is a condition called Valentino syndrome. So what happens is, in the epigastric region, there is pain, and after a couple, maybe a few hours, the pain is in the right lower quadrant. And the patient, when he presents to you, patient presents with only right lower quadrant pain. So you will think it is appendicitis, but actually what has happened, as per Valentino syndrome, you have had a perforation, a DU perf. Well, what happened? The contents leaked through the right side of the abdomen, going along, and this, there was an appendix that was sitting there. All this acid contents, after traveling through the, Morrison's area, right side of the abdomen, along the wall, and goes and touch the, acid is touching the gastric contents are touching the appendix, leading to an inflammation of the appendix. But is the pathology in the appendix? No. The pathology is in the epigastric. So if you remove the appendix, will that be helpful? No. The patient will still continue to be sick because you have not treated the primary problem in the epigastric region. That is your DU perf or your duodenal ulcer perforation. Suprapubic can have urinary retention, ectopic pregnancy, and PID kind of picture. So now, if you look at clinical examination, diagnostic clues, this is a very, very superficial slide. I'm going to, we're going to discuss this. So what happens is, if you look at, the abdominal exam, you look at it a very, very, intricate level. You have to look at first. You have to look at a clinical examination. You have to look at vitals. Very, very important. Is your vital stable or not? you do not forget your ABC. If patient is present in shock, do the hypotension management, make sure he's well hydrated. Then you come to the abdominal examination. However, don't go and straight put your hand on the abdomen saying where the patient says I have tenderness in the right upper part. Go and present that. So what happens is the patient might be guarding, or you might have so much pain, the patient is in discomfort, he may not allow you to examine the other regions. So preferably start at areas opposite to what his pathology is, so that he's comfortable with your hand. And when you do your deep palpation, by the time you reach the area of pathology, yes, you have ruled out the other areas. And then what? Otherwise, what happens when you touch the area of pathology, then there is, so much guarding, and, it may, evoke rigidity also. Now, at this time, you might be wondering what is guarding, what is rigidity I'm talking about. Well, I'm going to explain in the upcoming slides. So, general condition, vital signs, localization, extra abdominal causes, all you need to look at. And one very, very important thing we all tend to forget, I have also forgotten in my early years, what happens is a rectal examination. And what rectal examination is missed only in two conditions. Okay, rectal exam. When do you not do a rectal examination? Is in two conditions. Either your patient does not have an anal opening. Okay, and the other condition is when you don't have an index finger. So these are two conditions you should understand that you don't do a rectal examination. Okay. So it's very important to a rectal examination unless you have a very localized pathology there leading to severe bleeding, like fissure or on fissure in you don't cause, on humanitarian grounds, you don't cause pain there. You know that there is a rectal anal pathology there. Then you don't you hold on to your rectal examination. However, pelvic examination is mandatory in females. However, do not do per vaginal examination in unmarried females. It is a general understanding among all the clinicians everywhere that we do not do a pelvic examination in females who are unmarried. Okay. And with the consent only, you have to do all these things. And rectal and pelvic examination is really mandatory and required, leading to the life and so patient. Then definitely you will have to take consent and go ahead with the pelvic examination. Now, sometimes patient may not have a they may have undergone surgery. You have something known as a stoma, which is in the abdominal wall. So you have to check the ostomy, whether it's patent or you have anything that's occluding it. Whether tone is very high, is he having a some ulcer there or something. And when you do a per vaginal examination, you may be able to pick up something known as ectopic pregnancy. There might be fornicial tenderness. Fornices are there, per vaginal, there might be tenderness, and again, you might feel adnexal mass. So be very careful. And at the same time, these are all clinical tips. So you may ask the patient to cuff to elicit pain. So what happens is if he has a parietal pain, generally there's a pain on cuffing. If there's an obstruction, repeated vomiting of copious amounts of either bile stain or fecal material. If the patient is vomiting out feces, okay, means the obstruction is of a high grade or very it's a complete obstruction, and the patient is vomiting feces that is made and then is vomiting out. And if it's a pelvic inflammatory disease, that might be tender and thickened adnexing. So patient with visceral pain, so that's internal. Visceral is what? Some organ-related pain, okay? Simple organ-related pain. Patient with visceral pain are unable to lie still because they know there's some dull aching pain. It's just inside. They're not able to localize. So what happens is they will just try to keep moving around the bed. So if the patient is moving around the bed, your thing is, okay, he has pain, but maybe it's a visceral pain. And if it's peritonitis, something like surgical, so he will try to be immobile. Okay, he will not even try to move an inch. He will be absolutely, stable, because any movement will touch the peritoneal, inflamed peritoneum. And whenever there's a touching of the inflamed peritoneum, there's going to be severe pain. So patient will be, absolutely straight on the bed. He will not move an inch. And then that is another clinical way of understanding, yes, this patient has peritonitis, probably a surgical abdomen. Immediately refer the patient to a surgeon. Right from MBBS, even at PG level, there are, misunderstanding, I would say, between guarding and rigidity. It is not interchangeable. Please understand that. So whenever you're reporting to your seniors, you're trying to explain from one hospital to the other hospital, you're talking, between the two casualty doctors. Don't say guarding, rigidity, both are present. So what happens is guarding is a voluntary contraction of the abdominal muscle. I am trying to touch the abdominal wall, and suddenly this guy takes his hand, or he suddenly moves. So there's a contraction of the abdominal muscle. I can feel also the abdominal muscles being tightened on my touch. However, when I reassure him, when I try to, divert his mind, talk to him, divert his mind, then this voluntary contraction will reduce and I will be able to palpate the abdominal muscle. So that is your guarding. It may or may not be seen in peritonitis. The purpose of this is mainly to protect any inflamed organ. So when something is coming and touching, the abdominal wall, so the abdominal muscles will, try to prevent protect the underlying inflamed organ. The gentle palpation guarding may be overcome or reduced. However, if you look at rigidity, very important. If you look at rigidity, it is an involuntary. Guarding is voluntary. Whether you touch or not touch, it is severe stiffness of most surgical abdomen patient needs to undergo. Yeah. Am I audible? Yeah, great. So, so in rigidity, what happens is severe involuntary. That's the word, involuntary stiffness. Then even if you say, okay, you divert the mind of the patient, you talk to him, still he may not, that stiffness of the abdominal wall or muscles will not reduce. So rigidity is a significant sign of peritonitis. When you say rigidity, that's it. Sure. Rigidity, I'll explain again. It's involuntary stiffness of the abdominal muscles, whether you touch or you not touch. Why? Because it is inflammation of the peritoneum that is there, leading to so much inflammation that is there. The abdominal muscles are literally trying to, protect it, and it's become so tight. The abdominal muscles are not relaxing in between. Yeah, so the muscles are not relaxing. Even if you try to divert the mind of the patient, the abdomen wall will still be very tight. So that is called rigidity. In peritonitis, they say board-like rigidity. The table board or the surfboard that you have, the abdomen will be just like that. Usually, if you touch your abdomen, it is soft. It's going in, right? With these patients with rigidity or peritonitis, very important. It's involuntary. It continues, and it is seen in mainly in peritonitis. So I thought I'll just touch upon acute abdomen also just today. I'm just mixing theory, practical like that. So if you look at acute abdomen, denotes any sudden, spontaneous, non-traumatic disorder. It's got multiple definitions, whose chief manifestation is in the abdominal area, and for which urgent surgery may be required. So acute abdomen may mostly will require surgery. However, alternate definition, severe, often rapid onset abdominal pain necessitates prompt evaluation, management, and characterizes an acute abdomen, right? Again, another definition is sudden, spontaneous, severe abdominal pain, tenderness, and muscular rigidity. All right, that is less than 24 hours in duration, which may require an emergency surgery. So everything is pointing towards surgery. If you look at most likely the patient will undergo surgery. So because there's frequently progressive underlying intra-abdominal disorder, any delayed diagnosis very important. If you delay the diagnosis, patient will go into shock, patient will go into gangrene of the bowel. Anything can happen, and at the end of the day, by the time the patient reaches the next level, next hospital, he may be too far to be saved, and any treatment can affect the outcome. Now, if you look at investigations, I always tell my students, you treat the patient and just not look at the investigation. Sometimes the investigations can also be wrong. So you treat the patients and not just the investigation. You use the investigation to adjunct your understanding of the topic, and the patient, you treat the patient accordingly. So if you look at, investigations, I've kind of clubbed almost everything, something that you just need in one slide. Blood investigation, imaging, ABG may or may not be available in your setup, but if it is available, it gives a lot of answers immediately. Arterial blood gas analysis, you take an arterial puncture, immediately within 2 minutes, you get a report of your electrolytes, you get pH values, you get bicarb, you have PF ratio, everything required, how sick the patient is, will be by an arterial blood gas analysis. But many of you may not have that. So that can be avoided as of now. But if you're in a setup where you have an ABG, then there is no forgiveness if you don't do an ABG in a very sick patient, to understand how sick the patient is and whether he would require any intubation, put him on a ventilator, all that. So if you look at tests, if you look at the basic tests, let's start with CBC. What in CBC will you look at? I would mainly look at whether he's septic or not. So I need total counts, differential counts. CRP, ESR, again, markers of inflammation. When acute abdominal, they'll mostly be high. Okay. But mandatory tests, CBC, platelets, and definitely you need to have your coagulation profile, PT, APTT, INR. Sometimes in sepsis, these can be deranged, and you don't want to take a patient for to OT and make him continuously bleed and have a lot of issues. So LFT, liver function tests, whether his liver function is good, whether the liver is working well. Creatinine, very important. Amylase, lipase to rule out pancreatitis. What are your sugars? Urine analysis, any UTI. Of course, cardiac enzymes and troponin if the age and you have a high suspicion of underlying cardiac disease or other comorbidities. So abdominal X-rays can be used for obstruction. I'm going to, in the upcoming slides, I'm going to take some examples of abdominal X-rays. So please stay tuned, and for obstruction, perforation, any foreign body, stone, any chest pathology. Ultrasound, quite easily available at many centers. However, very interior centers may not have an ultrasound, or you may not have an expert who's done well qualified to do an ultrasound. So if you have an ultrasound, well, use it. Cholelithiasis, UTI, or any obstruction. Obstruction, not really an ultrasound will help. However, some signs are there, like reverse peristalsis, and also there's some outward obstruction. Now, how do I look at a normal abdominal X-ray? This is very, very important. Many of you have access to X-ray, but if I say, okay, I need to look at this X-ray and I don't know, sometimes my neighbor will bring an X-ray. So this is something is like a normal X-ray. Okay, if you look at this is the bowel. Okay, a couple of clinical tips I need to give you. There should be air in this area. Okay, for the rectal gas shadow. Means what? Gas travels much easier than solids or liquids. So when you're ingesting gas also, when you're taking a gulp, you're ingesting air. So that air continues to travel along your entire bowel and then finally comes out as flatus through your anal opening. So it says that, okay, that is patent. So if what is metal, this is probably an artifact. The pelvic bone, you have the femur, the bones here. And if you see, I'm not sure it's quite clear enough. This is the shadow. However, you have some, some material inside this. Okay. So what is that probably? That is feces. So when you have in the entire length of colon, this kind of picture, so this is called a loaded colon, or he's got constipation for a long time. He's not passed stools for whatever reason. Sometimes they may have spinal injuries or spina bifida patients, spinal injuries, which may, damage their nerves to, improve their bowel motility and all that. And so those patients may not be able to pass even, your rectal control, may not be able to pass well. So the stools will keep collecting and distend the bowel. So this is something like a loaded colon, what I was talking about. Multiple hyperechoic structures all around with air. Air is black. Okay. Why slight semi-grayish is probably stools in the gut. All right. So when you look at this, I would say, yes, there's some stools here. I would do per rectal examination. I feel stools and I get this X-ray. Probably has constipation. I have to rule out why he has constipation. whether it's any malignancy, elderly malignancy, don't miss a malignancy, any other pathology that is there, you need to rule out. And what does an erect chest X-ray do? It erect chest X-ray helps me, if I'm planning a surgery under general anesthesia, it will help me for my preoperative workup. However, any supra-diaphragmatic chest X-ray, many centers, they do lying down. The chest X-ray is absolutely a waste if you try doing it lying down, and many answers can be missed. However, when you're doing in a sitting or erect position, you will get more answers. Okay, any elevated hemidiaphragm, any diaphragmatic abscess is there. So that's right side will or left side, that particular area will be pulled up. If you have liver abscess, that area will be right side will be pulled up. Of course, there's a perforation, very, very important. Chest X-ray is the beautiful modality where it will tell you there's probably some underlying perforated bowel through which this air has leaked out and gone under the right diaphragm. So this is normal. If you see the right side, I'm trying to point here. If you see the right side, this is normal. This is fundic air bubble. Okay, but this left side, you see this diaphragm here, and you see crescent moon-like shape, means it is a surgical abdomen, no doubt. One very rare case is there, Chilaiditi syndrome, where the bowel goes above it, and the air in the bowel will, look like this. But more than 90% of the time, when you have a striking like this, abdominal pain, vomiting, constipation plus minus, you have this with an X-ray like this, it is perforation, peritonitis. You have to, refer the patient to a surgeon, and then he will do laparotomy and find out where is the perforation and do anastomosis, or bring it out as a stoma, whatever, wash the contaminants, whatever leak has happened of the stool contents, bowel contents, it has to be washed, because those are all irritants to the abdominal wall cavity. Now we look at abdominal X-rays. You can have supine view and you can have the erect view. So erect view, if you're suspecting obstruction, of course, I told you air in the rectum, any foreign body, you can help you. Multiple air fluid levels. I am not sure if you remember, you all had these Nataraj geometry boxes. And in those geometry boxes, you would have something known as a protractor. In school, we used to call it the D. D. Used to call it the D, protractor. Yeah. So if you have multiple air fluid levels, then you will like multiple protractors. I'm going to come in the upcoming slides, and you can see that in the abdominal X-rays, you can have that. Probably that is a sign of multiple air fluid levels is obstruction. So air fluid level mainly seen in the erect view. You supine view, you'll see more of dilated bowel loops. So here you see this is something a small bowel obstruction. You have the air fluid levels. Okay, as you see those protractor, you remember the protractor in school, like a D. Okay, so if you have this abrupt cutoff, then you will have to have this thing. So if you look at supine, you see these dilated bowel loops. Now, how do I identify what bowel loop is it? Is it ileum? Is it jejunum? Is it duodenum? How do I identify? So one mnemonic is ileum is featureless. By what I understand by featureless. Sorry.
Doctor, you're mute. 1 second, doctor. Doctor, can you please unmute yourself?
Yeah, okay, perfect. Okay, sorry. Yeah. So as you can see, now let's proceed fast. So again, if you look at this, all these are dilated bowel loops. You see a picture like this, there's some obstruction below this. You see this line. If there's a complete line, it's probably small bowel. Preferably, if this is called jejunum, dilated jejunal loops. So you have the duodenum, you have the jejunum, and you have, what do you have? What do you have, anyone? What is the third part of the duodenum? Ileum, right? Duodenum, jejunum, and ileum. So, as I told you, ileum is featureless. However, what are the other features So what are the other features? This is mainly the valvular conveyantum is complete, then it's probably jejunal loop. So if jejunum has to be dilated, something below that has to be obstructed. Means a transition point. If something above it has to dilate, means if it's a tube, if I constrict the lower part, the upper part will dilate because all your digestion juices, all the stomach contents, everything will try to flow against a complete obstruction. So if the jejunum is dilated, means your ileum is affected, probably having some pathology there. If your ileum is dilated, mean in those ileum, you will not have these lines. You have a dilated loop, but some lines here are very, very featureless. You may not have such prominent lines. In that, what will happen? You'll know that probably it's a even lower down like a large bowel obstruction. Okay. Yeah, and then your entire small bowel is dilated. So again, these are just to keep, again, I'm showing you the same image. Look at the D. If you have more than 3 Ds in an erect abdominal film, 1D, 2D, 3D, 4D, 5D. So all the D kind of thing, if you have, that is probably sign of multiple air fluid levels suggestive of intestinal obstruction. All right. Now this is a chest X-ray, air under diaphragm. Again, abdomen X-ray. Not so clear. Now, what are the indications for surgical exploration? We are nearing to the end of the lecture. What are the indications of surgical exploration? Sometimes if you have, guarding or rigidity, physical findings. Sometimes even, without any precise diagnosis. That's why they do something known as an exploratory laparotomy. If you don't have an imaging, ideally in this scenario, you should refer the patient to a center. If the patient is stable enough, refer the patient to a center where they can get a CT scan done or any imaging done, identify the pathology, and then, but however, in an X-ray, if you have air under diaphragm, okay, then the diagnosis is straightforward. You cut open, you explore, find out the perforation site. The surgeon has to find out the perforation site. Any unexplained abdomen condition with increased fever, probably underlying abscess, has to be drained. Some rectal bleeding with shock or acidosis, patient is sick despite your management. There's something that is happening in the abdomen. Abdomen is a Pandora's box. So what happens is you can't really guess immediately what's happening, but your clinical acumen plus 1 + 1 is equal to 2. So you will have to go along that guidelines, whatever I have tried to explain to you at different levels. Understand that what all could go wrong. As I told you, the multiple quadrants were all to understand this thing. So endoscopic findings you may or may not do in multiple in patients who are obstructed. Please understand, endoscopy is not do not do obstruction in patients. However, if it's an upper GI obstruction, you may do an endoscopy to find out the level of obstruction, what is the stage, and for biopsy also may be possible. Radiological pneumoperitoneum is the word. Pneumoperitoneum. It's an X-ray finding, CT finding. Progressive bowel destruction, obstruction is increasing. Extravasation of contrast, if you've given contrast. So if it's perforated, it will leak out in the abdominal wall. But ideally, should not give an oral contrast when you're suspecting a major perforation. Any mesenteric occlusion. You're suspecting, what happens is patients have severe abdominal pain. You've given tramadol, you've given diclo, you've given paracetamol, given multiple mefenamic acid. Still, the patient is just rolling in pain. Probably this is called symptoms are more than your symptoms are more than your signs. Your pain is more than your other symptoms. So that happens in mesenteric vessel occlusions. Okay. Yeah. Treatment of acute abdominal pain. I've been telling you how to treat acute abdominal pain all through the slide now. A little more concise. I'm going to algorithms and all that. It's almost nearing to the end of the lecture. I'll definitely answer all the questions towards the end. Treating hypotension. When a patient presents to you with an acute abdomen, BP is low, he may be in septic shock, he may be volumetrically depleted, urine output is low. Very, very important. You need to check urine output. So don't say that I will void, patient will void by himself. No, put in a catheter. Abdominal cause, suspecting anything acute abdomen, put in a urinary catheter unless there's any obvious contraindication for urinary catheterization. So put in a urinary data, put on monitoring, immediately rush fluids, provided this is a non-cardiac patient. Okay, if it's a cardiac patient, his EF is low, and you pump him with fluids, you will have a cardiac arrest before you treat your abdominal cause. So if the patient gives you a cardiac history, stenting done, your ejection fraction is low, he's having, he's on multiple cardiac medications, understand, or anti-failure medications. So understand that, yes, you cannot overload the patient. So once you give a basic fluid, once you give basic fluid, then you have to start him on vasopressors or noradrenaline, depending upon the cause. And you would give crystalloids, and you're treating your hypertension. Of course, you have to give antibiotics. And pain management. So sometimes some emergency doctors I have come across, they say, if I give pain management, he may not have pain, the surgeon will not find pain, and then a surgical cause might be missed. It's a very, very mixed thought of affairs. So if you, control the pain in such a way so that your signs are not even masked, however, moderate doses don't really obscure your physical findings. The masses may become more apparent with patient will allow you to examine if there's a mass in the abdomen. And pain in spite of your analgesia, suggesting serious condition. Pain out of proportion to symptoms, mesenteric ischemia. Out, no scan, nothing. Mesenteric ischemia is a high possibility. CT angio will kind of, say, okay, this is the level of obstruction. And you have to really act fast. Within 6 hours, you have to immediately, the earlier the better, they say, before there is a setting of gangrene. Antibiotics must be considered when you're treating suspected abdominal sepsis or diffuse peritonitis. First dose of antibiotics should go in as per surviving sepsis guidelines. It should go in immediately as soon as the patient presents to you. Immediately within the first hour itself, we give broad spectrum antibiotics. Okay. Coverage should be aimed at anaerobes and aerobic gram negatives. However, follow judicious antibiotic protocol in your areas. Don't just randomly shoot antibiotics just for, there's saying that many places, many patients come to the university saying, I have got monoceph or septum, third generation, which is, abused like anything at many centers abroad, at many centers, the rural areas, where whether you need it or not, patients are having fever, give him, ceftriaxone. Indication for admission. When do I say which abdominal pain? You're not feeling, getting that feeling, yes. If I send this patient home, 1 second. Yeah. So if I send this patient home, will he survive, will he not survive? Very young, elderly, admit, immunocompromised. Your abdominal diagnosis itself is not clear. You have not, you can't send the patient home. Intractable pain, nausea or vomiting, any altered mental status, patients with poor follow-up or non-compliant patients, you know that they will not follow up for their abdominal problem, alcohol or substance abuse, go ahead and admit them. You may have to, for alcohol and those kind of patients who are substance abuse, you may have to consider psychiatric help with medications, because they will have, with the abdominal pain in situ, they may even, start behaving in a very altered manner because they are getting withdrawal symptoms. Every day they're drinking alcohol, but when they don't get alcohol or drugs that their choice, then they go into withdrawal symptoms, and that withdrawal symptoms will present as even seizures, very, very sick seizures, and you may not know what your diagnosis exactly is. Ideally, there's nothing known as non-specific abdominal pain. You have to find the cause of abdominal pain. But despite all that, if you still say it's non-specific abdominal pain, you've ruled out all the organic causes, then still reassess the patient in 24 hours. And this can be done in an outpatient setting, provided you have ruled out all the organic causes. So this is just a broad algorithm. I have another algorithm also. So if you have generalized abdominal tenderness, abdominal guarding is there. All right, you do an imaging, clinical diagnosis is done, X-ray is done, and then all the bloods are given. If it's generalized, probably the patient is peritonitic. However, generalized abdomen without guarding is not guarding. Okay, some tenderness is there, is not guarding. Increased bowel sounds are there. Some abdominal distension is there. Very important. No, you're not suspecting an aortic aneurysm. Then again, you're doing all the basic imaging, consider ECG. If it's a pulsatile mass, it's suspected to be from the aorta. So abdominal CT scan with contrast. This line, if you go in, let me see if I can get this line. If you go in and you've done the imaging, no definitive diagnosis, CT scan of the abdominal pelvis, oral contrast, you may find differential diagnosis of peritonitis, bowel ischemia, obstruction, pancreatitis, or even aortic aneurysm. Air fluid levels, you have to treat for obstruction. Put an NG tube, IV fluids, NPO, very, very important. If a patient comes in with abdominal pain, abdominal syndrome, please don't feed the patient. Very, very important. Do not feed the patient. Give him IV fluids. Let his bowel rest. Understand the pathologies. Pain will be much, much better controlled if he is without food for at least 24 to 48 hours. But you may have to consider parenteral nutrition through special bags, parenteral nutrition through the IV line, either the peripheral or central line. You may, if you are thinking of keeping the patient NPO for a longer duration, as immediately after surgery, somebody has done, surgeon has done anastomosis and doesn't want food to pass through that, want some bowel rest and till the sutures are healing. So you may have to consider something known as total parenteral nutrition. That is specialized amino acids, your lipid profile, carbs are all mixed in a big bag, and then that goes through a central line into your vessels. Right. So, and your nutrition is managed. Acute abdominal pain. So you have something known as, I like this algorithm much better than the previous one. If you look at unstable vitals, your fluid resuscitating, urgent surgical consultation. If the patient is hemodynamics stable, no overt peritonitis, or there's some doubt of peritonitis, or even no overt peritonitis, you can still wait, assess the pain location. Evidence of peritonitis, consult a surgeon immediately. Where is the pain? So based on that, these are the tests you may have to order: chest X-ray, LFTs, ultrasound, whether it's a periumbilical lipase, epigastric. You're looking at lipase is more pancreatic specific, okay? More than amylase lipase, they say lipase is more specific. Left lower quadrants, do a pregnancy test, urine analysis, okay? Yeah, and when you're suspecting a woman, of lower abdominal pain and her LMP is not matching, definitely please, and she's married or unmarried, please proceed with a urine pregnancy test before subjecting her to ionizing radiations like CT scan. One last slide on abdominal compartment syndrome. So what if I don't do anything for the abdominal pain or say abdominal obstruction? So there is this abdominal distension happening. So at one point, it will just not burst, okay? Abdominal usually doesn't burst like that. So it's so distended. There's something known as abdominal compartment syndrome. You would have heard of limb compartment syndrome. When there's so much pressure, the vessels are compromised, and there's decreased blood supply to that. So it's abdominal compartment syndrome. The normal pressure is 5 to 7 millimeter of mercury. Intra-abdominal pressure, abdominal pressure more than 12 mm mercury. And what will happen? The vitals organ blood supply will get cut off because there's so much pressure inside. It will press onto your IVC, aorta, all that, and increase the pressure. Blood supply will decrease. So what are the non-surgical options for low grade? If it's a low grade, abdominal compartment syndrome, you can put an NG, decompress, sedation, blockade. Some diuretics can help. So high grade, what happens is, particularly when the renal or respiratory function is compromised because of decreased blood supply, or the laparotomy with creation of an open abdomen is the most effective. You'll have to cut open the abdomen, relieve the pressure, find out. So you can have a primary abdominal compartment syndrome, pathology in the peritoneal cavity. That is a pathology in the peritoneal cavity itself. Sometimes massive bowel edema secondary to shock, other reason, can cause secondary bowel injury. Some organs inside the abdominal compartment is leading to abdominal compartment syndrome, like organs, massive bowels and all. Tertiary is obviously abdominal wound closure. So surgeon has closed the wound so tight, okay, there's no place for it to literally expand. So that itself intra-abdominal compartment pressure. So what happens is intra-abdominal hypertension is there, and then finally underperfused viscera leading to an abdominal compartment syndrome here. Low blood supply plus increased abdominal pressure leads to an abdominal compartment syndrome. So these are the risk factors, as I told you, for abdominal compartment syndrome and intra-abdominal hypertension. Some abdominal surgery, pancreatitis, high BMI, burns, mechanical ventral peritonitis. All these the multiple commodities, multiple problems that mentioned here, and prone positioning can also, increase the abdominal compartment syndrome. So normal is less than 12, 1, 12 to 15. This is the grade of intra-abdominal hypertension. So increase in that. So how do you check it? You put in a Foley's catheter and, to the urinary bladder. Then, connect a device to which you can understand the abdominal pressure. Sometimes some patients will be admitted in your hospital and then they start developing abdominal pain. You would have treated for some leg condition and suddenly he's having abdominal pain. So these are the multiple problems, because of multiple antibiotic, Clostridium difficile associated colitis, constipation, typhlitis, some coronary underlying cardiac event is happening. Sometimes critical illness, physiological stress, pancreatitis is a possibility, acalculous cholecystitis. So the diagnosis and treatment of acute abdominal pain is a very collaborative work, often starting in the emergency department. So this is like a kind of a summary slide. If you look at different areas, what all conditions you need to, look at, whether pain in the right, center, left, how is it? You look at right gallstones, something to do with the liver, kidney stones, appendicitis here, center, heartburn, hiatal hernia, even MI possibility, umbilical hernia. Left is functional gas, stomach ulcer, pancreatitis. Because pancreas will be even, starting from center here, going up to the left. So it's a big organ. Kidney stones, constipation, IBS, irritable bowel disease. IBS is more of a psychiatric involvement. Indications for referral. So whenever I have generalized tenderness, uncontrolled vomiting, not settling, patient's clinical condition is worsening, GI bleed is there, palpable mass, severe unexplained pain, much better to refer. So this I thought will help you, in the exam point of view. Sorry. Multiple signs here, that's, and its association. So sometimes you have very, very commonly known McBurney's tendon and McBurney's sign. So it's mainly for appendicitis. Murphy's is for cholecystitis. Again, Rosing for appendicitis. Manipulation of cervix causes patient to lift the buttocks of the table. That's the chandelier sign seen in pelvic inflammatory. Gray Turner's, again, discoloration of the flank. You have the pancreatitis possibility, and retroperitoneal hemorrhage is also a possibility. Cullen sign is bluish periumbilical discoloration. Again, pancreatitis bar retroperitoneal hemorrhage. As you know, pancreatitis is a retroperitoneal organ. So yeah, I think we have come to the end of our presentation. Vijay, should I leave the thing on this slide or how do you want to do it?
Yes, doctor. Yes, doctor. So, doctors, thank you for joining. Thank you. Thanks for the session. Certificate, we were able to find that there was a lot of problems in clicking the link. So we have created this. So scan the QR code. Doctor, there is a window on the QR. Yeah, there is a QR code. I'll also drop the link also to further help you well. 1 second. Yeah, the certification registration link is also been dropped on the chat box. So if you have any questions, please ask questions at chat box. Dr. Alen will answer your question. Dr. Girgari asking score for pancreatitis.
No, there are much more questions on the top. Can we start from there?
Yeah, please. So we'll do one thing. We'll keep the slide in this. So you can scan the QR code and leave us the feedback, and meanwhile you can answer the questions. Thank you, doctor.
So Vijay, you can just sorry. Second, just let me go up. Okay, so Dr. Dilshan has said, sir, in critical patients unable to take, chest X-ray erect. Absolutely correct. In ICU patients, it's difficult. Especially needy patients also, it is difficult. So what you can do, if your hospital bed allows, you can do a semi-recumbent position. You can take it at an angle, okay? Put in the chest X rather than taking it absolutely at a, 0 degree. Bring him up by at least 60 degree, 45 to 60 degree. That itself will also serve the purpose. Next question, just look at it. Yeah, so Dr. Twinkle has explored laparotomy, resection, anastomosis. So what happens is whenever you do a laparotomy, straight away three things. Either once you find the pathology, if it's in the bowel, you find the pathology. Either you will be able to anastomose it immediately in the surgery itself. But if there's so much contamination, sepsis, stool, which has leaked to the cavity, try to anastomose, because if you know your anastomosis will fail in the next few days. So you will bring out one of the loop of the stoma into the abdominal wall called the stoma. So you not always do a resection and anastomosis. You can bring it out as a stoma, and in the second surgery after 3 to 6 months, once he becomes better, we apply the thing, dismantle the stoma and redo the surgery and remove, and so that he's passing stools normally.
Thank you, Dr. Alen, sir. Good evening, sir. I want to speak regarding a little bit detail about the stoma. So, how to take care of the stoma, especially in the ICU critical care conditions, to prevent the infection, and what is
Sorry, your voice is
pathology of
quite low. So, Dr. Twinkle. Hello, can you hear me? Just 1 second.
Give us a minute. The speaker will be back. Dr. Twinkle.
Now, yeah, I'm just trying to see what's the problem with the audio.
Yeah. Dr. Twinkle, meanwhile, while we wait, is it possible to drop the question in the chat board, or if you can wait, you can directly talk to the doctor in 1 minute?
Get the audio through the phone.
There is slight technical glitch. Please bear with us for 2 minutes. Dr. Alen will be joining through another device, which will rectify the error. Dr. Twinkle, please, 2 minutes. I think you can directly talk to the Dr. Alen. He will be connecting back.
Yeah. Dr. Twinkle?
Good evening, Dr. Alen, sir.
Yeah.
Sir, I am working in the critical care unit. So I see so many patients who's post laparotomy and resectional anastomosis and developing a stoma. But after few days later, the stoma becoming unfunctionable and gangrene. So can you share a little bit detailed information how to take care the stoma and to see the pathology and all to prevent the infection?
All right. So, what happens is, Dr. Twinkle, you need to understand what is the actual reason for which I hope I'm audible. Yeah.
Yes, sir. Yes, sir.
Yeah. So you need to understand why you are having uh, the stoma, why it was created in the first place. Was it an obstruction, or was it because of severe sepsis? So all that, what happens is stoma, when it's created, if your blood supply, it's a very surgical technique oriented thing, and if your blood supply to that point where you're bringing out the stoma into the abdominal wall, if that blood supply is compromised because of any reason, then the stoma will necrose. Okay. But if you are saying the stoma is working well, means it is throwing out the contents that is there in the stoma, but the skin around, which is a very common problem, the skin around the stoma has become so red and angry looking, then it is you need to understand the application of the stoma bag has some issue, or the stool that is coming out is coming in contact with the skin, because of which there is a burning sensation, there is erythema, there's redness all around. So much so that even sometimes the stoma, after a few days, the stoma bag does not stick to the stoma. I hope you would have seen that kind of thing. Yeah. So, okay. So look at the next question. Uh, So again, Dr. Twinkle has said corpus luteal rupture cyst is very common finding, especially in young females with lower abdominal pain with missed cycles. Yes, it is a possibility. And however, in young females, you should not miss something known as a ruptured ectopic, which is again many a times it's a condition that is preventable cause of death. Okay, because patient by the time. Hello, am I audible? Vijay, am I audible?
Yes, sir.
Great.
Yes, sir.
So, yeah, great. So, sometimes what happens, preventable cause of death, this ruptured ectopic cyst, you should understand when the pregnancy happens outside, the area it should not happen in. So, I mean, if it occurs there, then you have, ectopic. And usually it happens at the ampulla, infundibular ampulla region. And if you have it in any other area, then you will, of course, you can have a thing, and that since that is not compatible with life, after, as soon as the fetus grows, it will rupture and cause severe bleeding and hypotension. Yeah. And all right. Pediatric abdominal pain. Dr. Ajit Kumar has asked a question on acute abdominal pain in pediatrics, identification and treatment. Wow. It's a different, completely different topic altogether, especially, when you cater to the pediatric population. I was thinking of including it in the lecture, but I thought already the lecture has gone off beyond many slides, so I didn't want to include it. We'll look at it at a different date. However, to answer your question, if you look at pediatric abdominal pain, many of the abdominal pain, the children are not able to express it. They will only, unlike adults, it's difficult to diagnose the abdominal pain in children. So many of them can have, parasitic infections, very common. You can have, say, jaundice. Of course, you'll have other clinical signs associated with fever. You may have underlying fever. And then the other thing is UTI, very common in children when they don't hold their urine and they don't pee or they drink less water. So all that UTI is a possibility. And some of late, we're seeing a lot of children with mesenteric lymph nodes, enlarged mesenteric lymph nodes. We don't know the reason why. Mostly could be underlying tuberculosis, especially in areas where they consume, milk that is not boiled or pasteurized. The abdominal TB rates are quite high, especially in the Punjab belt. Um, so yeah, so pediatric also, the multiple mesenteric lymph nodes can cause non-specific, abdominal pain. You might not be able to localize the cause, but yes, the patient is or the child is crying to you in pain, may have stone, may even have a basic UTI. But in pain tolerance in children is by invariably quite low. So any even mild pain, I think they will just start crying, and then they will not let the parents sleep also, so that the patient needs to be shown to a pediatrician and managed accordingly. Post GI surgery and anesthesia used for surgery went in paralytic cases. If you look at anesthesia, yeah, it does wear out after a few hours. No anesthesia is really, unless you have an underlying, say, liver compromise, or you say have a renal compromise, usually a liver compromise, where the anesthetic agents are slowly getting depleted and you have a prolonged anesthetic period. So in those conditions, paralytic ileus in case of sepsis, in prolonged bed bound. So what happens? What we do it in patients of abdominal surgery, maybe by the second day or the third day, we make him ambulate into the ward. So once he starts ambulating, his gut also starts moving inside, and then he's able to pass through. Of course, electrolyte imbalance is very, very important to rule out, paralytic ileus. You might have in low potassium, and because of which there is, paralytic ileus. You correct the potassium, you start passing stools. Yeah. So score for pancreatitis. Dr. Gregory has asked score for pancreatitis. Dr. Gregory, pancreatitis has multiple scores. Okay. Again, it depends. See, severity of the pancreatitis, and more importantly, if you look at prognosis of pancreatitis. So there are multiple scores like, you have the Ranson score at admission, you have Ranson score at 48 hours of thing, then you have the Atlanta score. So you have multiple scores like that. But at the end of it, what does these scores imply? These scores imply that, okay, what will be the prognosis or mortality? Pancreatitis is a very bad disease to have. India has two major causes of pancreatitis. One is gallstone, the second one being alcohol. Western, it's usually the alcohol first, then comes to your gallstone. In India, is slowly becoming westernized. So yeah, so all that multiple causes are there for pancreatitis. But yeah, so the score is made to predict the in what prognosis would be the pancreatitis heading to. Is pain scale, Dr. Jason has asked, is pain scale still considered as the most accurate to measure level of abdominal pain, or are there any reliable ways? So, pain scale or pain scoring is still a valuable tool where a lot of, especially the nursing staff understand the pain score. They usually try to, chart the pain score for us. Sometimes the patient may say, I have only 2, but by the time the consultant comes, he will say, no, I have, say, about 5. So it is very subjective, which is actually based on what patient says. Okay. And of course, a patient may say 10 pain and then, sitting up or walking around in the ward. That's just impossible. So you have to correlate clinically along with that. And any other ways of measuring abdominal pain, pain per se is experienced by the patient himself. Only he will be able to tell, how much pain does he have, and it's a very subjective pain. So pain score of 2 for me, maybe 5 for somebody else. A pain score for 7 of somebody else, maybe, again, depends on the threshold of how much he can hold. In constipation, so there's another question, Dr. Dilshan. In constipation, rectum is full of stool. Can we give lactulose without excluding obstruction? Ideally, you should have at least an X-ray to see that, okay, do you have dilated bowel loops? So dilated bowel loops, multiple fluid levels. Do you have? Rule out an obstruction. Always safe. What happens is when you give these lactulose kind of syrup, if there is a partial obstruction, there is a stimulus that is created and the partial obstruction will become complete obstruction. So you don't want that to happen. Okay, something that could be managed medically, you've made it surgical. How to manage stoma care? Very good question. Stoma care ideally is a multi-modality. It requires dermatologists, surgeons, stoma care sisters, especially. So it starts right from the time before surgery. When the patient is going for surgery, stoma care nurses do come and mark the stoma site. So once they mark it, so if that is an measurement that is done so that the stoma bag will sit very nicely, it will not come more into the wound or more laterally, not come into the belt line. All that is calculated in such a way the patient is comfortable, the doctor is also comfortable in making the stoma. So once that you manage how to manage stomach care, very important. A lot of patients come with skin excoriation. You might have to apply zinc oxide, wait. You may have to allow it to heal, and then keep applying bags, the special pastes that are available in the bag. Okay, to apply so that your skin excoriation won't be there. Yeah. In which scoring should we follow in acute pancreatitis and about complications of acute pancreatitis like hyperglycemia, hypoglycemia? So Dr. Gregory has asked this question: which scoring we should follow? So there is nothing like hard and fast rule whether you should follow Ranson's or you should follow Atlanta. There are multiple scorings, as I said. Okay, and
Sir, hello.
yeah,
Sir, myself, Dr. Gregory, sir.
hi,
So
Dr.
my
Gregory.
doubt is like, if a patient comes to ER and based on what scoring I should admit the patient to ICU or like what, like the severity scoring we should follow for the admission case.
All right. So if you look at say pancreatitis scoring, say Ranson scoring. So Ranson's also includes an ABG and all that, provided you have ABG in your center. So if you don't have an ABG, you can't do a half-hearted Ranson with some parameters, and some parameters not being there. So if you have an ABG in your setup and you're able to follow that, and of course, more importantly in pancreatitis, it's fluid management. And if your patient presents in shock, if your patient presents in severe pain which is not responding to medications, then definitely these are the criteria for admission. There is not anything particular score. Unlike they say appendicitis, you have Avogadro Mantel score, Alvarado score. Okay, this is highly likely to be pancreatitis. Sorry, highly likely to be appendicitis. So you admit the patient, do the surgery. So all this is quite subjective. Again, depends on the clinical situation of the patient. There are pancreatitis cases which have been managed on OPD basis also. Okay, your amylase lipase levels, but that level does not. Some centers do repeated amylase lipase levels. So, ideally, I would say amylase lipase only needs to be done once. This serial measuring of lipase is, it is anyway showing a decreasing trend, means patient is getting better. No, not even if patient may present in another hospital 1 week, he would be there, and by the time he comes to you, their lipase is normal, but he's not settled. Does not mean that he did not have pancreatitis. He would have had now the complication of pancreatitis, which happens in the second week or the third week of pancreatitis. So, based on that, whether the patient is sick, septic enough, or you think the patient is hypotensing, severely dehydrated, do an ABG, find out his lactic, and what is acidotic status. All that, those are criterias for your admission. No particular score that okay, if he's above 5 or 6, you have to admit. That way, you will end up filling up your entire ward, and you will not have beds for really sick patients.
Thank you, sir.
Sure. Dr. Kirti has asked mesenteric lymphadenitis. So mesenteric lymphadenitis is quite commonly seen in multiple conditions like tuberculosis, lymphoma, mainly in intra-abdominal sepsis also. It's like a chronic kind of disease seen as a reaction to which the mesenteric lymph nodes get enlarged. So as you know, lymph will track the infection or the pathology itself, and that gets inflamed. So it's not a disease per se, but because of mesenteric lymphadenitis, especially in children, what happens is the lymph nodes become big and they start hanging down, and and they start irritating peritoneum, start touching peritoneum, and then all that leads to kind of the pain stimulus getting activated. As I told you, children have lesser threshold to pain. Dr. Nasneen has asked, can ureteric colic cause constipation or loose motion? And why? Because both happened with patients. Please explain. All right. So, ureteric colic, stone in the ureter. There's so much pain. As I told you, the sphincter, if you remember, when there's severe pain as a stimulus, your sphincter goes into spasm. Okay. Your pyloric goes into spasm because you end up having vomiting. So even these voluntary sphincters go into spasm, and you can have constipation. And that is one of the causes for constipation. Apart from that, why loose motion? Loose motion, if you have anything in the pelvic, say pelvis, some free fluid is there, some infected fluid is there, that will irritate, rectum, and then that can also cause loose motion. But urinary colic per se causing loose motion as such, you have to really look into if you see any other, underlying pathology. Maybe he would have been given a CT scan or oral contrast before it. So, yeah, that may be a possibility. Yeah, and going to the next question. So, regarding abdominal compartment syndrome, how many hours can we keep the 12 mm? Oh my God, this is a very, controversial question. In laparoscopic surgery, you have to maintain 12 mm pressure until the finish of surgery. Perfect question. I like it, Dilshan. Thank you. So now the thing is, abdominal compartment syndrome, you should understand it's closed compartment. All right, completely closed. And what happens is, how many hours can we keep it? There's no specific rule that you can keep it like that. But as soon as you're suspecting abdominal compartment syndrome, which is mainly because of a pathology underlying it, primary, secondary, okay, underlying pathology is there, then you need to understand that you need to act fast and see where do a laparotomy, relieve the pressure, what needs to be done immediately, whether he's going into any kind of mesenteric ischemia, bowels getting compromised, blood supply is getting compromised because of that. And like you said, in laparoscopy, you have to maintain 12 mm pressure. Not always. You can start at 8, 10, 12. Of course, many surgeons do prefer in between 10 to 12. Now, what happens is it is 1 hour procedure, 2 hour procedure. However, in between, you end up releasing some gas. Okay, you end up there are multiple procedures that are happening. You are taking off your instrument, one instrument, putting in the next instrument. So what happens? Some gas gets leaked out. So even though the 12 mm pressure is there, it is not an absolute. It is something the abdominal wall is able to manage. If, for example, good question. For example, if your abdomen is not able to tolerate 12 mm pressure, your anesthetist will tell you that the heart rate is dropping because there's so much pressure that it starts compressing onto the pericardial region, and the heart rate will slowly start dropping, and the anesthetist will ask you to reduce the pressure in your abdominal gas, and then you'll have to work at lower pressure. So that itself will tell you, yes, the patient is not able to tolerate my 12 mm. I may have to work at a 10 mm HG pressure. And yes, when you're taking out the sample, in between, you're again relieving gas, you're removing the thing. Yeah. Now, many oral diabetic agents also use, commonly they develop pancreatitis, drug induced. Twinkle doctor has said, and good to achieve, also it is good to achieve glycemic control. Yes, I agree with Dr. Twinkle. Oral diabetic agents can cause drug induced pancreatitis, but that's predominantly in the long run. Then they may have to switch to some, insulin agents if the orals are not working. Then they will have to switch into this one. Drug-induced pancreatitis, more commonly, as Dr. Gregory has put it across, very well written. Retroviral cause drugs, azathioprine, thiazides, even your Caesar medications can cause. I've had a couple of patients with valproate sodium valproate induced pancreatitis, phenytoin induced pancreatitis. So we had to stop and change the drug. So mainly the phenytoin induced pancreatitis is quite common. Investigation to rule out aneurysm, ultrasound abdomen is there. At the same time, you can have a CT angio that you can do from diaphragm to toes to rule out aneurysm. Of course, clinically, how do I say? When I touch, I feel an abdominal mass, which is pulsatile. Do not press further and burst it in the abdomen.
Great, doctor. I think we have answered all the questions.
Perfect. Long session, huh?
Indeed, and
But
long.
it's a good class. I think it was a good interactive class we had. I think if I get a good, I mean, I understand feedback is important, whatever good or bad. I mean, honest feedback is more important and
Yes,
good feedback. So if you could share the feedback link, and then only certificates I think would be issued.
yes,
Something
doctor.
that is a thing that is auto linked. That's not that we do it, but it's auto linked to the system. And also, people, I am coming in with, soon I'm coming in with the series of lectures on gallstones, management of polylithiasis. It's a 5-week lecture, once a week, maybe the weekends or something. Coming soon with that thing, complete course package. It's 5 lecture, and people interested can definitely, show your interest, and soon it will be a very, very nominal fee that is there just to support the advertisements and all that we do. Yeah. So more importantly, scholarships are also available, and complete management of polylithiasis, right from the basic understanding to surgery, and going ahead, how we can proceed. And our main importance is for these doctors who are in the periphery, managing ICUs and all by themselves. And yeah, I prefer to keep my lectures very, very simple and basic, down to earth kind of lectures, not using much of medical terms, because I understand things very, very, in a very lucid way, and I believe this lecture was much useful to many. Sure. Shall we call it a day then? Any other? Thank you,
Yes.
Dr. Kriti. Thank you, Dr. Twinkle. Thank you, Dr.
Oh,
Gladdy.
okay, doctor.
Thank
Great.
you.
Hey, doctor. Thank you for the insightful session. I personally learned a great deal. And this is one such session I personally always uh, sit throughout the session because your session is always as good as it's new. And I'm sure all the doctors agree with me. On behalf of everyone, I extend our sincere gratitude to Dr. Alen. It is this
Thank
kind
you.
of engagement and participation that motivate us to organize more such sessions. We also have dropped our social media links in the chat box. Please do follow our channels to get to know more about our upcoming webinars. We have back-to-back webinars. We are conducting a lot of webinars on a monthly basis. Please do follow us on social media and do attend all our webinars. Thank you, doctor. Thank you so much. Thank you, everyone, for joining us this evening. Those who have registered in the form, they will get the certificate. Those who have not, for the previous webinars, also you will get. Not to worry. Once you have registered, it is rest assured your certificate will reach out to you. Thank you so much. Thank you, everyone.
Sure. Thank you all. Good night.
Good night, doctor. Good night to all.